Good morning, class. Myself, Dr. Soumya. I am going to discuss about mycotic infections in detail. So, mycotic infections. Mycotic infections are fungal infections of animals, including humans. Mycotic infections are common and variety of environmental and physiological conditions can contribute to the development of fungal diseases. Inhalation of fungal spores or localized colonization of the skin may initiate persistent infections. Therefore, mycotic infections often start in the lungs or on the skin. As we all know, the most important fungal infections are Candida albicans, angular cheilitis, thrush. Is are the most important fungal infections that occur in our oral cavity. So, the fungi that causes subcutaneous mycotic infection normally reside in soil or on vegetations. They enter the skins by traumatic inoculation with contaminated material. In general, the lesions becomes granulomatous and expand slowly from the area of implantation to local lymph nodes. So extension, how it is going to extend in our body? By lymphatics. Mycotic infections are usually confined in the subcutaneous tissues, but in rare they become systemic and produce life-threatening disease. So what are the causes? Who are at the risk? The people that are risks when they are taking strong antibiotics for a long period of time, that long period of time, because antibiotics kill not only damaging bacteria but also the healthy bacteria. So this is the favorable conditions to grow of fungi. So this alter the balance of microorganisms in the mouth, vagina, intestines and other places in the body and results in an overgrowth of fungus. So it is also occurs in the individuals with weakened immune systems. With HIV/AIDS, fungi infection is the most common thing under steroid treatments and taking chemotherapy. Chemotherapy patients also has fungal infections and mainly oral thrush. With diabetes also tend to develop fungal infections. Very young and very old people also are groups at risk. So how it is going to invade in our body, how it occurs, we have to know about pathogenesis. The response to infection with many fungi is the formation of granulomas. Granulomas are produced in the major systemic fungal diseases like coccidioidomycosis, histoplasmosis and blastomycosis. The cell mediated immune response is involved in granuloma formation. Activation of the cell mediated immune system results in delayed hypersensitivity, skin test response to certain fungal antigens injected intradermally. Acute services suppression, pyogenic response characterized by the presence of neutrophils in the exudate also occurs in certain fungal diseases such as aspergillosis and sporotrichosis. So if we want to know about what is the thing which is in fungal infections, what they have unique characteristic, we can say that the presence of neutrophils in the exudate. So, intact skin is an effective host defense against certain fungi, like Candida dermatophytes. If the but the skin is damaged, organism can become stabilized, and the non-normal flora of the skin and mucous membrane suppress fungi. If there is in an intact skin, if the skin is not damaged, so there is a no chance of fungi to grow in our skin. But when the normal flora is inhibited by antibiotics, the overgrowth of fungi such as Candida albicans can occur. So we are going to discuss about candidiasis. Candidiasis are also known as candidosis, monoliasis, and thrush. So these are the important names of candidiasis. So, the fungal infection of oral mucosa most frequently occur due to a species of Candida albicans. Infections is a short-lived. It occurs on the superficial skin, but it can be fatal. So, Candida is present as a commensal organism in the mouth, up to 40% of subjects with clinically normal mouths. The number of organisms in the saliva of the carrier increased with pregnancy, tobacco scuffing, and the with wearing of dentures account for 80% of nosocomial fungal infections. So, in pregnancy, the person who is chewing tobacco, the person who is wearing dentures, they are more susceptible to the Candida albicans. Candida is also present as a commensal organism in throat, lung, bowel, and vagina. The primary oral reservoir for the organism in the carriers in the dorsum of the tongue. So, isolation of candida from mouth of an adult is not confirmatory evidence of infection and must be considered together with the clinical findings. The histological findings, the main finding of any fungi is hyphae. If it contains hyphae but not spores, it can confirm the diagnosis. Hyphae is the must thing in histopath condition of the fungi. Budding cells of varying size that can form both elongate pseudohyphae and true hyphae. Forms of white pasty colony with a yeasty odor. Both general and local predisposing factors are important in the pathogenesis of oral candida infections. For example, debilitated patients, such as those receiving antibiotic, steroid, or cytotoxic therapy, are particularly susceptible to candida infections, with local factors, tobacco smoking, trauma, and xerostomia. As we discussed earlier, that if there is any crack in the skin, if the skin is not proper, then the chances of candida is going to be more. So, what are the factors that is going to predispose to oral candidal infections? So, there are the three factors: local factors, age factor, drug factor. In local factors, we have any trauma, if we have denture wearing, tobacco smoking, that the person somehow have lip biting habit. So in this case, Candida can be grown in age, extremes of age, neonates, infants, old age. And in drugs, we have discussed earlier broad spectrum antibiotics, steroids, local ischemic, or any immunosuppressant disease. In xerostomia conditions, we generally take the medicine which is also known as pilocarpine. In drugs, radiotherapy, Sjogren syndrome. In also systemic diseases like iron deficiency anemia, megablastic anemia, acute leukemia, diabetes mellitus, HIV infection, immunodeficiency status. So, classification of oral candidiasis is done in two parts. First one is acute and second one is chronic. First one, acute, is also known as acute pseudomembranous, also known as, the main thing to notice is acute pseudomembranous, also known as oral candidosis thrush, and acute atrophic oral candidosis. And second one is chronic. Chronic has three parts: chronic atrophic candidosis, also known as denture stomatitis. Second one is chronic mucocutaneous candidosis, also known as chronic familial, chronic localized, chronic diffused. And third one is chronic hyperplastic candidosis, also known as candida leukoplakia. So, first we are going to discuss about the oral candidosis thrush, which is the most common. So, it is the most common form of the candidosis, generally associated with the local disturbance or systemic illness. Thrush occurs in 5% of newborn infants, which is probably associated with immature antibacterial differences. Also, it's seen in about 10% of elderly debilitated patients. So, in this picture, we can appreciate the oral thrush. the person having uh, Candida albicans, the person having oral thrush has also symptoms of pain or burning sensation, altered taste, and the predisposing factors is also xerostomia, antibiotics, and decreased host resistant immunity. If immunity of person is hampered, then every conditions can along with it. So how can we identify, is it the thrush or another thing? First, it presently clinical soft, thick white coating, slightly elevated plaques. The white plaques on the affected mucosa, which can be wiped away to leave a red or normal appearing mucosa. So, the first characteristic of oral thrush is it can be wiped away. The white plaques grossly resembling milk curd. So, milk curd uh, like area is also known as thrush. It has consist of tangled masses of fungal hyphae with intermingled desquamated epithelium, keratin, fibrin, necrotic debris, leukocytes, and bacteria. Lesion may occur on any mucosal surface of the mouth and vary in size from small patches to confluent lesions covering a wide area. Most frequently present on buccal mucosa and tongue, and also seen on palate, gingiva, floor of mouth. In several cases, entire oral cavity may be involved. But the most common site of oral thrush is buccal mucosa and tongue, and the tongue, which part? Dorsum part of tongue. So next we are going to discuss about acute atrophic candidosis. Acute atrophic, also known as erythematous candidosis, and also known as antibiotic sore mouth, seen most commonly on the dorsum of the tongue in patients undergoing prolonged corticosteroid or antibiotic therapy. In Candida albicans, there are three: acute part and chronic part. In acute part, we are discussing the second thing. First one has white appearance. Second one, the acute atrophic, is has red appearance. It presents as red rather than white, and often painful area of oral mucosa, which resembles thrush without the overlying pseudomembrane. It comes under the category of erythematous candidosis, includes central papillary atrophy of tongue. Chiliocandiasis also occurs as sequelae to a course of broad-spectrum antibiotics. The person which has this uh, chiliocandiasis suffer from generalized pain, burning, arrhythmia, may occur at any site, red and consistently painful. Central papillary atrophy of the tongue in median rhomboid glossitis. This is not a painful condition. In this condition, the person is asymptomatic. It has symmetric appearance, erythematous lesion on dorsal aspect of post region of tongue, just anterior to the foramen cecum. So this is the main thing, how to identify the median rhomboid glossitis. Red, deep papillated, smooth or fissure due to loss of filiform papilla. It has a strong association with chronic smoking, and it is etiological debate developmental or chronic candidal infection. Next, we are going to discuss about chronic atrophic candidosis, also known as denture stomatis. The name itself has the big explanation of this. This is common and usually symptomless condition found in 50% of denture wear, more frequently in women than in men. Clinically, there is chronic erythema and edema of the mucosa directly covered by the denture. The palate is visually affected, but it is very unusual to see lesions related to lower denture. So, denture stomatitis occur mostly in palate region, mostly in maxilla. Secondary infection by candida in tissues modified by continual wearing of dentures, poor denture hygiene, high carbohydrate diet. May be asymptomatic. Candida colonize the denture surface. Minimal or no candidal invasion of mucosa is present here. So clinically, this is how we can identify the denture stomatitis. First, pinpoint of erythema, localized inflammation is present. Second one is diffused area of erythema, generalized inflammation is present. Third one is erythema associated with granular or multinodular mucosal surface, chronic inflammatory papillary hyperplasia. Now we are going to discuss the most important thing, angular cheilitis, which is most common nowadays. Multifactorial disease of infectious origin, fungal or bacterial or combined. Candida or Staphylococcus aureus or Streptococci is present. It is also in mainly in denture wearers patient. 30% patient with denture stomatitis have angular cheilitis. Clinically, characterized by soreness, erythema, cracks, crust, pain, and fissuring at the corners of the mouth. Loss of vertical dimension, deep folds of skin at angles of mouth, and nutritional deficiency, iron, folic acid, B12. So, if the person comes with folic acid deficiency, the person has also a chance of angular cheilitis. So next one we are going to discuss about chronic hyperplastic candidosis, also known as candida leukoplakia. So it the name suggests it is a adherent white plaques on the oral mucosa. We all know that how the leukoplakia looks. So they cannot be removed by scraping. The oral thrust we have discussed is removed by scraping, but this candida leukoplakia, they can't be removed by scraping, but fragments may be detached, and identification of hyphae in smears of such material assist in diagnosis. So this is how candida leukoplakia looks. The most frequent location is lips, tongue, buccal mucosa at commissures. It is considered to be a pre-malignant lesion, and epithelial dysplasia is seen in about 50% of cases. It has not been conclusively shown whether chronic hyperplastic candidosis primarily leukoplakia with a secondary candidal infection, whether it's a primarily a chronic candidal infections, which in time leads to epithelial hyperplasia and acanthosis. So we can't know it is a primary or it is a chronic candidal infection. According to Cohen and Binney, there is a definite relationship between chronic candidiasis and oral epidermoid carcinoma. Based on this, chronic candidiasis itself is a cause of leukoplakia and thus must be regarded as having possible pre-malignant potential. So this is the main characteristic, how chronic chronic candidiasis can lead to pre-malignant potential. In second point, we are seeing that Roy Peterson and his associate have reported a high incidence of candida organisms and occurrence of cytological epithelial atypia in the biopsied lesions of leukoplakia. So next we are going to discuss about chronic mucocutaneous candidosis. So this is how chronic mucocutaneous candidosis looks like. This is a group of disorders characterized by persistent superficial and candidal infections of the skin, scalp, nails, and mucous membranes. Oral mucosa involved in most cases, similar to chronic hyperplastic candidiasis, and occur in same intraoral locations. So, oral manifestations occur in numerous forms of candidiasis, and these have been categorized and modified by Liner and include the three things. First one is chronic localized mucocutaneous candidiasis. Second one is chronic diffuse mucocutaneous candidiasis. Third one is candidiasis endocrinopathy syndrome. So chronic mucocutaneous candidiasis has three subgroups, and what are the features we are going to discuss now. So in first case, severe form occurring in early life, no genetic transmission, widespread skin involvement, and granulomatous and hardening masses on scalp, nail, and face. In second one, chronic diffuse mucocutaneous candidiasis, least common form of late onset, severe skin and oral lesions, raised crusty sheets involving grain, limbs, face, scalp, shoulder, nails, and mouth. Third one is candidiasis endocrinopathy syndrome. It is the genetically transmitted mild and moderate oral and skin lesions, hypoparathyroidism, addition disease, diabetes mellitus, or ovarian insufficiency. Now we are going to discuss about deep fungal infections. Etiology and pathogenesis. Deep fungal infections are characterized by primary involvement of the lungs. Infections may disseminate from this focus to involve other organs. Oral infections typically follow implantation of infected sputum in oral mucus or may also follow hematogenous spread of fungus from another site such as the lung. Oral manifestations of deep fungal infections. Oral lesions are relatively uncommon, presenting most frequently as non-specific ulceration or as nodular granulomatous lesion. So, there are the classification of this deep fungal infections. First one is North American blastomycosis, also known as Gilchrist disease. Second one is South American blastomycosis, also known as Coccidomodicomosis. And third one is histoplasmosis, also known as the Darling disease. And fourth one is coccidomycosis, also known as the San Joaquin Valley fever. Fifth one is cryptococcasis. Sixth one is phycomycosis, and seventh one is sporotrichosis. So we are going to discuss about the Gilchrist disease. So in this disease, the organism is blastomycosis dermatitis. This is a free living, as the name suggests, North America. So it is found in the soil of the large section of North US. Inhaled 10 to 100 Conidia convert to yeast and multiply in lungs, affects mainly lungs, and nearly 50% of those infected show cough and fever or no symptom. It may spread to other parts of the body. Skin is involved in 20% to 40% of cases. The cutaneous feature. Skin lesions are common on the face, neck, and the extremities as the infection spreads from the lungs to other parts of the body. The lesion begins as papule, pustules, and a subcutaneous nodule. Within weeks to months, the lesion develop into ulcers and form crusty sores. Clinically, this is how it's look. Clinically, the chronic, non-healing oral ulcer may resemble those of epidermoid carcinoma and cervicofacial actinomycosis. So, by seeing actinomycosis, I can only remember the question came out in recent paper is actinomycosis contains which granules? It has a sulfur granules. Over a period of months to years, lesions grow larger and heal to form raised wart-like scar. Lesion may cover much severe disfigurement. So the basic inflammatory response is granulomatous. In the presence of these microorganisms, macrophages and multinucleated giant cell dominate the histological picture. So histological features we can see, it has the inflamed connective tissue, so giant cells and macrophages, and typical round budding organisms with doubly reflectile capsule measuring between 5 to 15 microns in diameter. So treatment. So fungal treatment, any conazole, anything is like itraconazole, fluconazole is the treatment, oral treatment of this disease. And also we can also suggest the amphotericin B IV. Next, South American blastomycosis, also known as paracoccidomycosis, and the organism is Paracoccidioides brasiliensis. It is, the name suggests, it is also occurs in North America, North American blastomasis, South America, South American blastomasis, and the non-lung infections occur through inhalation or inoculation of spores. Systemic lesions are similar to those of North American blastomycosis. The organism enter the body through periodontal tissues and subsequently reach the regional lymph nodes, producing lymphadenopathy, papillary lesions, and widespread ulceration of the oral cavity. The difference between North and South American blastomycosis is in size of microorganisms. South American blastomycosis is larger in size and North American blastomycosis is smaller in size. The size of South American blastomycosis is 10 to 16 microns, and in North American blastomycosis it is only about 5 to 15 microns. So diagnosis and treatment. Presumptive diagnosis made if budding yeast cells and pseudohyphae are found. Growth are selective. Differential media differentiate Candida species. Topical antifungals for superficial infection, amphotericin B, and fluconazole for systemics. Next, we are going to discuss histoplasmosis, also known as Darling's disease or Ohio Valley fever. Histoplasmosis, the name suggests it is caused by Histoplasma capsulatum, worldwide in distribution. Although it is endemic in the northeastern United States, the organism multiplies in soil enriched with the droppings of birds and bats, and the spores remain viable for years. Infection is by inhalation of infected dust containing spores of fungus, excreta of birds such as pigeons, starlings, and blackbirds. So pathology is parasite in its yeast phase multiplies the monocytes and macrophages and produce areas of necrosis where parasites may abound. From this foci, the bloodstream may be invaded, producing metastatic lesions in the liver, spleen, and lymph nodes. Pulmonary histoplasmosis may produce changes similar to those of tuberculosis. So the ulcerated areas are covered by non-specific gray membrane and are indurated. They appear as nodular, ulcerative, or vegetative lesions on the buccal mucosa, gingiva, tongue, palate, or lips, and we can appreciate in this picture. Histoplasmosis just showing macrophages with cytoplasmic microorganisms. So how we are going to manage? We are going to manage by giving IV amphotericin B and total dose of 1.5 gram followed by itraconazole. Ketoconazole is also going to treat histoplasmosis. Next is the coccidioidomycosis, also known as San Joaquin Valley fever. So it coccidioides imitis causes coccidioidomycosis. Distinctive morphology: block-like arthroconida in the free-living stage and spherules containing endospores in the lungs. Lives in alkaline soils in semi-arid hot climates and is endemic to southwestern US. Arthrospores inhaled from dust creates spherules and nodules in the lungs. A skin eruption resembling erythema multiform occasionally appears concomitantly with coccidioidomycosis infections, and treatment is amphotericin B. Now we are going to discuss about cryptococci. Cryptococcus neoformans causes cryptococcisis, a widespread encapsulated yeast that inhabits soil around pigeon roost, common infections of AIDS, cancer, or diabetes patients. Infections of lungs leads to cough, fever, and lung nodules. Dissemination to meninges and brain can cause severe neurological disturbance and death. Diagnosis and treatment. Diagnosis is just amphotericin B and fluconazole. Next, we are going to discuss phycomycosis and also known as gycomycosis. So, phycomycosis, also known as mucormycosis, as we all know, mucormycosis after this corona, fungal infection caused by the general mucor and rhizopus, organisms in the family of fungi, which normally are found in bread mold or decaying fruit and vegetables, are opportunistic, infecting humans when systemic health is compromised. In the head and neck, lesions are most likely to occur in the nasal cavity, paranasal sinus, and oropharynx. Pain and swelling precede ulceration. Tissue necrosis result in perforation of palate, extension into the orbit or brain is a common application. The fungus has a predilection for arterial wall invasion, which may lead to infarction. Phycomycosis or gycomycosis. The microscopically, we can see the pale staining non-septate hyphae that tend to branch at obtuse angle. Round or ovoid sporangia and also frequently seen in tissue sections. Now we are going to discuss sporotrichosis. Sporotrichosis is caused by Sporothris scandkai, lives as a saprophyte on plants in many areas of the world, in which portal of entry is not entirely understood, reported to occur after exposure to animals, accidental injury to thorns of plants, lab or clinical inoculation of hospital workers. How it is going to pathogenesis. Subcutaneous fungal infection affect first subcutaneous tissues, result from inoculation of the skin or mucosa by contaminated soil or thorny plants. After an incubation period of several weeks, subcutaneous nodule which frequently become ulcerated develop. Systemic involvement is rare but may occur in individuals with suppressed immune responses. Clinical manifestations. How it looks. Involve skin, subcutaneous tissue, oral, nasal, and pharyngeal mucosa. Skin lesions appear as red papule, often described as sporotrichotic cankers. Forms at the site of inoculation. Oral lesions are described as non-specific ulcerations healing by soft pliable scars. Over the next several weeks, similar nodules form along proximal lymphatic channels. The nodules intermittently discharge small amount of pulse and ulcerations may occur. So diagnosis, culture of pus, cultured on SDA, and the size of this sporotrichosis is 3 to 5 microns, less than the North American blastomycosis. Laboratory diagnosis. First, we can go for direct microscopic examination. Second, culture of the organism. Third, DNA probe test. And fourth is serological test. Direct microscopic examinations. We can also see because in any fungal diseases we can see the asexual spores hyphae or yeast in the light microscope. The specimen is either treated with 10% KOH to dissolve tissue material, leaving the alkali resistant fungi intact, or stained with special fungal stains. Some examples of diagnostically important findings made by direct examination is spherules of C. immitis, white capsule of Cryptococcus neoforms, seen in India in preparation of spinal fluid. Calcofluor white is a fluorescent dye that binds to fungal cell walls and useful in the identification of fungi in tissue specimens. Methanamine silver stain is also useful in the microscopic diagnosis of fungi in tissue. So this is how smear is prepared. PAS stain, also known as periodic acidic per acidic skiff stain. We can see the hyphae is present here. Next, we are going to discuss about the most important thing in which fungi are cultured is Sabroids agar. which facilitates the appearance of the slow growing fungi by inhibiting the growth of bacteria in the specimen. Inhibition of bacterial growth is due to low pH of the medium, chloramphenicol, glycohexamide. The appearance of the mycelium and the nature of the asexual spores are frequently sufficient to identify the organism. DNA techniques. Tests involving DNA probes can identify colonies growing in culture at an earlier stage of growth than can tests based on visual detection of the colonies. As a result, the diagnosis can be made more rapidly. At present, DNA probe tests are available for coccidioides, histoplasma, blastomycosis, cryptococcus. Serology. A significant rise in the antibiotic titer must be observed to confirm a diagnosis. The complement fixation test is most frequently used in suspected cases of coccidioidomycosis, histoplasmosis, and blastomycosis. In cryptococcal meningitis, the presence of the polysaccharide capsule antigens of C neoforms in the spinal fluid can be detected by the latex agglutination test. So, we are going to now discuss about antifungal therapy. The most important antifungal drugs, as we all learned about amphotericin B and the various azoles, exploit the presence of ergosterol in fungal cell membranes that is not found in bacterial or human cell membranes. Amphotericin B disrupts fungal cell membranes at the site of ergosterol, and azole drugs inhibit the synthesis of ergosterol, which is an essential component of fungal membranes. Another antifungal drug, caspofungin, inhibit the synthesis of glucan, which is found in the fungal cell walls but not in the bacterial cell walls. This is a plus point. Human cells don't have a cell wall. Treatment modalities. Look for underlying cause and treat it. If antibiotics or corticosteroids are the cause, reduce the dose or change the treatment. Intermittent or prolonged topical antifungal may be necessary when the underlying cause is unevolvent. Denture cleaning is necessary. Antifungal agents. First one is amphotericin B. Second one is azoles. Azoles are considered better, but they are expensive. Newer azoles may be required in invasive or resistant infections. Antifungal agents. Flucytosine, active against Candida and Cryptococcus species. Fluconazole has been against oral candidiasis and HIV disease. Nystatin is often used for candidiasis. The complications of this drug. These drugs can go for drug resistance, drug interactions, and adverse effect. Structural defects or loss of function resulting from fungal destruction of the maxilla, orbit, and/or cranial base. Prognosis. Most fungal infection in healthy individuals are self-limiting and have a good prognosis. If a deep fungal oral lesion develops, the lesion likely represents an potential serious underlying infection. Although most deep fungal infections respond to aggressive antifungal therapy, infections can be fatal. So we are concluding it. The most deep fungal infection have their primary foci in the lungs. Therefore, those presenting with distant organs or skin involvement should be managed aggressively, as untreated or severe disease can lead to severe scarring, disfigurement, and even death. We have seen also in corona that mucormycosis is leading to death in some patient. So the difference of this class is Oral Pathology Books of Ragazzi in Safers and the Color Atlas of Clinical Oral Pathology. Thank you all.